Pleasant day to everyone. We are the group assigned in discussing the concept of cardiomyopathy.
Before proceeding to the discussion, let us be familiarized by these three words that were put together: cardiomyopathy. Cardio meaning the heart, of course, myo meaning the muscle, and pathy means disease. So basically, a muscle disease of the heart, which it is difficult for the heart to pump out blood to the rest of the body and could be leading to heart failure. Now, there are three types of cardiomyopathy: the dilated, hypertrophic, and restricted cardiomyopathy. From the word dilated, the chambers becomes thin, stretched, and grows largely, mostly starting in the heart's main pumping chamber. The hypertrophic becomes thickened, typically affecting the muscular wall between the two bottom chambers of the heart. While the restrictive cardiomyopathy, it is where the muscle tissue in the heart's lower chambers becomes stiff, and this prevents the ventricles from filling with blood properly, reducing blood flow in the heart. The heart is a four-chambered hollow muscular organ, normally the approximate size of a fist. It lies within the thorax in the mediastinal space that separates the right and left pleural cavities. The heart is composed of three layers: a thin inner lining, the endocardium, a layer of muscle, the myocardium, and a fibrous outer layer, the epicardium. The heart is surrounded by the pericardium, a fibroserous sac. The heart is divided vertically by the septum. This creates a right and left atrium and a right and left ventricle. The thickness of the wall of each chamber is different. The atrial myocardium is thinner than that of ventricles, and the left ventricular wall is 2 to 3 times thicker than the right ventricular wall. The thickness of the left ventricle is necessary to generate the force needed to pump the blood into the systemic circulation. The right atrium receives venous blood from the inferior and superior vena cava and the coronary sinus. The blood then passes through the tricuspid valve into the right ventricle. With each contraction, the right ventricle pumps blood through the pulmonic valve into the pulmonary artery and to the lungs. Blood flows from the lungs to the left atrium by way of pulmonary veins. It then passes through the mitral valve and into the left ventricle. As the heart contracts, blood is ejected through the aortic valve into the aorta and thus enters the high-pressure systemic circulation. The four valves of the heart serve to keep blood flowing in forward direction. The cusps of the mitral and tricuspid valves are attached to thin strands of fibrous tissue termed chordae tendini. Correct me if I'm wrong. And they are anchored in the papillary muscles of the ventricles, making the support system prevent the eversion of the leaflets into the atria during ventricular contraction. The pulmonic and aortic valves prevent blood from regurgitating into the ventricles at the end of each ventricular contraction. The myocardium has its own blood supply. The coronary circulation. Blood flow into the major coronary arteries occur primarily during diastole. The left coronary artery arises from the aorta and divides into main branches: the left anterior descending artery and the left circumflex artery. These arteries supply the left atrium, the left ventricle, the interventricular septum, and a portion of the right ventricle. The right coronary artery also arises from the aorta, and its branches supply the right atrium, the right ventricle, and a portion of the posterior wall of the left ventricle.
So I'll be discussing the predisposing factors and the precipitating factors of cardiomyopathy. So in predisposing factors, we have here the modifiable and the non-modifiable. Under the modifiable, we have here the sedentary lifestyle that elicit drug use, obesity. So sedentary lifestyle. Engaging in regular physical activity and avoiding prolonged periods of inactivity can help improve cardiovascular health and reduce the risk of cardiomyopathy. By incorporating exercise into daily routines, individuals can strengthen their heart muscles, improve blood circulation, and maintain a healthy weight. Illicit drug use. Illicit drug use such as cocaine and amphetamines can have detrimental effects on the heart, including the development of cardiomyopathy. By avoiding illicit drug use, individuals can reduce the risk of cardiomyopathy associated with these substances. The obesity. Excess body weight, particularly when accompanied by unhealthy eating habits, can strain the heart and increase the risk of cardiomyopathy. By adopting a healthy diet and engaging in regular physical activity to achieve and maintain a healthy weight, individuals can reduce the risk of developing cardiomyopathy. So, in non-modifiable, we have the age and the family history. So, the age. The chance of getting cardiomyopathy rises with aging. This is due to the possibility that the heart muscles may gradually deteriorate or lose effectiveness over time. While we cannot stop aging process, we can still manage other modifiable risk factors and encourage general heart health by leading a healthy lifestyle. So next is family history. Family history. Cardiomyopathy or other heart problems run in the families, which raises the risk of developing them. This raises the possibility that disorder may be inherited. Unfortunately, our genetic makeup and family history cannot be changed. However, being aware of a family history of cardiomyopathy can encourage people to be more watchful about their heart health and get right kind of screenings and medical guidance. So, in our precipitating factors, we have acute coronary syndrome and myocardial ischemia.
Good morning, everyone. So now we will discuss the pathophysiology of cardiomyopathy. So we have here three types of pathophysiology of the dilated, restrictive, and hypertrophic cardiomyopathy. So I'll first discuss the dilated cardiomyopathy. But before we go into the disease process or pathophysiology of dilated cardiomyopathy, I will first give some important information about this disease. So, dilated cardiomyopathy is the most common form of cardiomyopathy. It is also called as congestive cardiomyopathy, in which it affects the chambers of the heart by weakening their walls. So now let's proceed to the disease process of dilated cardiomyopathy. The etiology of dilated cardiomyopathy is idiopathic or unknown. In dilated cardiomyopathy, the primary issue here is there is a dilation of the ventricular chambers and atrial chambers. The chambers of the heart are being stretched and loosens all the valves so they don't close all the way. So this result in weaker contractions or decrease of contractility which result to pump failure. So the blood here doesn't go forward and backs up into the lungs and into our body. And when the blood backs up, this means less oxygen is being pumped out of the heart to the body, so there is decrease or less cardiac output. So cardiac output is the amount of blood expelled by each ventricles per minute. So less cardiac output meaning there is less oxygen in the body. As a result, the body thinks that we have low blood pressure, so the body attempts to increase the blood pressure by stimulating the sympathetic nervous system to increase the heart rate. It also attempts to increase the blood pressure by stimulating the kidneys to initiate the renin-angiotensin-aldosterone system or the RAS system, which result in the kidneys holding on to fluids, which increases blood pressure. But over time, these compensatory mechanisms can no longer maintain cardiac output and the heart begins to fail. So the signs and symptoms of dilated cardiomyopathy are hypoxia, angina, and dyspnea. So that is all for the pathophysiology of dilated cardiomyopathy.
So now I will be discussing the pathophysiology of restrictive cardiomyopathy, or the RCM. So it refers to a set of changes in how the heart muscle functions. These changes causes the heart to feel poorly, which is the more common, or squeeze poorly, the less common. So sometimes both problems are present. So RCM is a condition where the chambers of the heart become stiff over time. Though the heart is able to squeeze well, it's not able to relax between beats normally. This makes it harder for the heart to fill with blood. The blood backs up in the circulatory system, and this can cause fluid to build up in the body, including the lungs, which leads to many of the symptoms of the condition. It also increases the pressure inside the ventricles, and the atria can become enlarged. There is also an increased risk for irregular heart rhythms. Eventually, this disease makes the heart unable to pump as much blood out to the body as it normally would. So most people with RCM eventually develop heart failure, and it is a fairly uncommon form of cardiomyopathy. So RCM is not always a primary cardiac disorder. Although the cause is usually unknown, it may arise as the consequence of systemic or genetic disorders. So the etiology of RCM is idiopathic or unknown, but there is an endocardial thickening or myocardial infiltration. So sometimes with death of myocytes, papillary muscle infiltration, compensatory myocardial hypertrophy, and fibrosis, which may occur in one or typically the left or both ventricles. So as a result, the mitral or tricuspid valves may malfunction, leading to regurgitation if nodal and conduction tissues are affected. So the sinoatrial or the SA and atrioventricular node malfunction, sometimes causing various grades of SA block and AV block. So RCM is characterized by non-compliant ventricular walls that resist diastolic filling. One or most commonly the left or both ventricles may affected. The main hemodynamic consequence is diastolic dysfunction with a rigid non-compliant ventricle, impaired diastolic filling and high filling pressure leading to pulmonary venous hypertension, and systolic function may deteriorate if compensatory hypertrophy or infiltrated or fibrous ventricles is inadequate. So, symptoms include fatigue and exertional dyspnea and chest pain. So, pulmonary venous hypertension can lead to mural thrombi formation. So, these are the thrombi that attach to the wall of blood vessel and cardiac chamber. Mural thrombus occurrence in a normal or minimally atherosclerotic vessel is a rare entity in the absence of hypercoagulative state or inflammatory infectious or familial aortic ailments. So, in a small blood vessel, blood flow may be completely cut off, or it called occlusive thrombus, resulting in death of tissue supplied by that vessel. So if there is mural thrombi formation, there is a possibility that systemic emboli may occur. So systemic emboli is the emboli which travel through the systemic arterial circulatory system, and the vast majority of these arise within the heart secondary to atrial fibrillation, or the altered flow or thrombus formation over an area of myocardial infarction, which is the altered wall. So systemic emboli can lead to restrictive cardiomyopathy, in which it can lead to heart failure.
One type of cardiomyopathy is due to autosomal dominant disorder. There is some type of genetic mutation within the proteins which is the sarcomere. Sarcomere proteins are proteins that makes up the skeletal and cardiac muscles. This include your actin, your myosin, and your troponin. So what is sarcomere proteins? Sarcomere proteins represents the structural building blocks of heart muscles which are essential for contraction and relaxation. So if there is a mutation within one of these proteins, this reduces the sarcomere function, or what we call as sarcomere dysfunction. So when there is a reduction of sarcomere function, this triggers the cardiac cells na moingon nga, uy, need na tumubuhat og way to function properly so that we can maintain good cardiac performance. So this triggers the cardiac cells to increase the secretion of different types of growth factors. And when these growth factors are released, it's going to try to stimulate an increase in myocyte growth and thickness. It's going to cause them to multiply and to get bigger and thicker, causing myocyte hypertrophy. So what is myocytes? When I say myocytes, these are cells within the heart's tissues that generates the tiny electrical impulses that causes the heart muscle cells to contract. So, di ba? So, ingon dire, if the growth muscles, if the growth factors are released because the cardiac cells, there is a dysfunction of sarcomere, the cardiac cells will release different types of growth hormones, and when these different types of growth hormones are released, it's going to stimulate and increase growth of myocytes, and it causes the myocyte to grow bigger and bigger and to be thick and stiff, causing myocyte hypertrophy. And because there is a hypertrophy of the myocytes, this results for the septal wall or the interventricular septum, which is the wall that separates the left and right ventricle, to become very thick and stiff. The septal wall or the interventricular septum and the left ventricular wall becomes very thick and stiff, and it makes the left ventricle less compliant or being less stretchy. The signs of symptoms of this is angina, because there is a very thick septum wall and myocardial wall is not getting the oxygen and blood that it needs. Because it's large and thick, it causes the patient some ischemic pain, which signals the myocardial blood flow is not meeting myocardial oxygen. Therefore, the patient will manifest angina. So if there is a less or ventricular compliance, the blood coming in from the atrias going into the left ventricle, since there is not a lot of space, it alters the filling process. When the blood is coming in from the atrium to the ventricles, that is called diastolic filling. During diastole, our muscles relaxes and the filling of bloods occurs. However, if the left ventricle is thick, causing it to have decreased compliance of, it will reduce the diastolic filling process, and therefore reduced preload will eventually decrease stroke volume, causing decreased cardiac output. And one of the signs of symptoms of this is dyspnea, which is an initial symptoms that is manifested by the patient. So this type of cardiomyopathy is what we call as hypertrophic cardiomyopathy, which commonly occurs in the left ventricle. To sum up, left ventricle is affected because of the different genetic mutations that affect the different sarcomere proteins. And because of that, there is a muscle growth asymmetrical. The interventricular septum grows larger relative to free wall. Hypertrophy occurs wherein the walls takes up more space. There is a decreased blood filling or diastolic filling. The walls become stiff, less compliant, less filling, low stroke volume, and low cardiac output.
Hi, I'm Reginald Allen Tadik. So I will be discussing the complication of cardiomyopathy. So heart failure is cardiomyopathy can weaken the heart muscle, making it less effective at pumping blood, resulting in heart failure. So this can lead to symptoms like shortness of breath and fluid retention. So next is heart valve disease. So, cardiomyopathy may cause enlargement of the heart chambers, leading to the heart valve problems such as regurgitation or stenosis. Next is cardiac arrest. So, in severe cardiomyopathy, it increases the risk of cardiac arrest where the heart suddenly stops beating, often due to irregular rhythms. Next is stroke. In some cases, blood clots can form in the enlarged heart chambers, increasing the risk of stroke if these clots travel to the brain. Next is cardiogenic shock. So this is a life-threatening condition where the hearts cannot pump enough blood to meet the body needs, often caused by severe myopathy. So next is arrhythmias. In cardiomyopathy can disrupt the heart electrical system, leading to abnormal heart rhythms, which can cause palpitation or fainting.
So nursing care plan. So the objective is tachycardia, arrhythmia, increase or decrease in pulmonary vascular resistance, decrease peripheral pulses. So nursing diagnosis is decreased cardiac output related to altered contractility as evidenced by dyspnea. Scientific basis, susceptible to inadequate blood pump by the heart to meet the metabolic demands of the body, which may compromise health. So objectives, general, after 5 days of student nurse intervention, the patient will be able to understand the prevention on how to decrease cardiac output. Specifically, the patient will be able to demonstrate decreased episodes of dyspnea, angina, and dysrhythmias. So nursing intervention, assess and monitor for clients' chest pain because it can also accompany cognitive heart failure. Evaluate client's report and evidence of extreme fatigue to assess for signs of poor ventricular function and impending cardiac failure. Keep client on bed or chair rest in a position of comfort. So this decreases oxygen consumption and the risk of decompensation.
Activity intolerance related to imbalance between oxygen supply and demand as evidenced by reports of fatigue and weakness. Objective cues. Abnormal blood pressure response to activity. Abnormal heart rate response to activity. Exertion discomfort, exertion dyspnea, and fatigue. Scientific basis according to Nanda. Activity intolerance is a classic sign of patients with cardiomyopathy along with other symptoms like dyspnea at rest or on exertion, fatigue, and athopnia. This is a direct result of decreased cardiac function. Objectives. General. After nursing intervention, the patient will be able to increase their activity level to perform desired activities. Specifically, the patient will be able to understanding of potential loss of ability in relation to existing condition. Identify alternative ways to maintain desired activity level. Indicates decrease in physiological signs of intolerance such as pulse, respiration, and blood pressure is still within normal range. Interventions. Assess cardiopulmonary response to physical activity including vital signs such as blood pressure, pulse, and respirations during and after activity. Because any dramatic changes in heart rate and rhythm, changes in blood pressure, and progressively worsening fatigue result from an imbalance of oxygen supply and demand. Determine current activity level and physical condition with observation, exercise capacity testing, or use of functional level of classification system as appropriate. The rationale for this is to provide baseline for comparison and an opportunity to track changes. Provide or recommend assistance with activities. Although help may be necessary, self-esteem is enhanced when client does some things for themselves. Lastly, instruct client in proper performance of unfamiliar activities. The rationale for this is to conserve energy and promote safety. Therefore, the client was able to perform ADLS without assistance. The client has an understanding about the possibilities of losing the ability in relation to the disease.
Okay, so these are the laboratory tests used in diagnosing cardiomyopathy. So first is chest x-ray. So an image of the heart will show whether it's enlarged. Next is echocardiogram. It uses sound waves to create image of the heart which shows its size, motion, and beats. Next is cardiac catheterization. It can reveal blockage in blood vessels. Cardiac MRI. It uses magnetic fields to create image of the heart if endocardiogram aren't helpful. Next is cardiac CT scan used to assess heart size, functions, and heart valves. And last is the blood test. It is used to check the function of kidney, liver, and thyroid, also to measure iron levels. Blood tests help in assessing the type of cardiomyopathy. So now let us proceed to the medication management of cardiomyopathy.
So now let's move on to the medication. The first drug is the hydralazine, and its brand name is the apresilin. Its classification is peripheral vasodilator. Its indication is moderate to severe hypertension with a diuretic, and its therapeutic effect is lowering of blood pressure in hypertensive patient and decrease afterload in patient with heart failure. And the next drug is enalapril malate, and its brand name is Vasotec. Its classification, it is an ACE inhibitors. Indication, treatment of hypertension alone or in combination with other antihypertensive adjunctive therapy for symptomatic heart failure, treatment of asymptomatic ventricular dysfunction. And its therapeutic effect is in hypertension, it reduces peripheral arterial resistance. In heart failure, it increases cardiac output, decreases peripheral vascular resistance, decrease blood pressure, and decrease pulmonary capillary wedge pressure, and decrease heart size. And the next drug is verapamil, and its brand name is Verilan. Its classification it is a calcium channel blocker. Indication, treatment of hypertension, angina pectoris, supraventricular tachyarrhythmias or the SVT, atrial fibrillation or flutter, off label, treatment of bipolar disorder or the manic manifestation, and hypertrophic cardiomyopathy. And its therapeutic effect is it decreases heart rate, decreases myocardial contractility, slows SA, and AV conduction. It decreases total peripheral vascular resistance by vasodilation. And the next drug is propanolol, and its brand name is Enderal LA. Its classification is it is a beta adrenergic blocker, and its indication is treatment of angina pectoris, arrhythmias, essential tremors, hypertension, hypertrophic subaortic stenosis, migraine, headache, pheochromocytoma, prevention of myocardial infarction. And its therapeutic effect is it slows heart rate, decreases blood pressure, decreases myocardial contractility, and it decreases myocardial oxygen demand. And the last drug is it is anifedipine, and its brand name is Afeditab CR. And its classification, it is a calcium channel blockers. And indication, treatment of angina due to coronary artery spasm or the Prinzmetal's variant angina, chronic stable angina or effort-associated angina. Extended release, it is also a treatment of hypertension. And its therapeutic effect is it increases heart rate, increases myocardial oxygen delivery, um, increases also cardiac output, and decreases systemic vascular resistance, and decreases blood pressure.
So prognosis, research estimates that more than half of all people with CHF will survive for 5 years after diagnosis. About 35% will survive for 10 years. However, in some cases, a person can extend their life expectancy through lifestyle changes, medications, and surgery. So that's all. Thank you.